Polyp. This is the focus of today's episode of GRWM, endometrial polyp.
Get reporting with me. I'm Dr. Matthew Leonardi. I'm here to teach you how to interpret ultrasound. We'll cover everything from the basics to advanced techniques. So whether you're a student, a healthcare professional, or just curious about ultrasounds, I hope you'll join me for the reporting ride.
For a little bit of background, we have a patient in her 30s. The requisition has pretty much stated abnormal uterine bleeding, specifically heavy menstrual bleeding since the delivery of her last child. She's had a few children, and she's had 3 vaginal deliveries in total. It's time to get into the case. Let's go. Beginning with image number 1. Image number 1 is a transabdominal image without a full bladder, and we can appreciate our uterus is here, but you cannot really appreciate any pathology in this case because the uterus is not really overall that much larger, and there is no gross myometrial or endometrial pathology. You do have a little bit of a sense of where the endometrium is, a little bit of a midline linear echo right there, but not a whole lot else. All right, not much in the adnexa, visible on transabdominal views, both sides. Uterus again in transverse, nothing exciting, moving along. There's an ovary here, but you can see we just have a hypoechoic shell, really. We're not seeing much in the way of follicles, cystic lesions, not particularly useful, which is generally how I feel about transabdominal imaging. We do get a measure here. So if we're trying to get a sense of is this bigger or not from usual, this is a normal volume, around 6.5 milliliters of volume. All right, moving on to the uterus. And my sonographers know that the cine is where the magic happens. So we're starting off with a right to left cine of the uterus, right side to the left side. And so far it's played a couple times. So maybe some of you have already seen Pathology. Obviously, a little bit of a spoiler at the beginning of the video around which pathology we're going to be focusing a little bit on today. So let's get into it. Pause the clip and let's scan through. So we have our vessels. We're starting to get the lateral aspect of the uterus. Here's the endometrium coming into view. And we have a bit of a midline linear echo there. It's just here is where the first sign caught my eye. Actually, around here, we're starting to see this shift in where that linear echo is in terms of a directionality, but especially right here in this area here, we see a sudden shift in the angle of that linear echo there, which gives us a sense that there might be some space occupying lesion in the anterior aspect of that endometrium. Not only that, but we are also getting a bit of a sense of a hyperechoic ovoid structure in that anterior endometrium there. And you can see that structure as I just hover back and forth in that area. So I'm pretty convinced already that there's a polyp, but let's see what we get in the next stills and videos. What else should we look at in the uterus during this cine loop? We should look for other features of pathology like adenomyosis, fibroids, congenital anomalies even. So as we scan from right to left, if we follow this line, this is one way to assess for congenital anomalies. We can just watch that line essentially come straight through the screen right at us without dipping into the myometrium centrally. So that looks already like a pretty normal contour uterus from a congenital anomaly standpoint. From an adenomyosis standpoint, we're looking for direct and indirect features. Starting with some indirect features, it's not a globular uterus. We don't have really a light bulb shape or a sudden shift in angle between the cervix and the myometrium. I'm not really getting much in the way of fan-shaped shadowing coming from the myometrium. Remember, and we've talked about this in one of the previous videos, we often do get a sharp demarcation of fan shadow there at the interface of the fundal endometrium and the myometrium, but that doesn't count. We're getting a little bit of fan-shaped shadowing from this area up here as well, which are the arcuate vessels. Not really any coming from that posterior myometrium, and not really any coming from this area here, which is the real area of myometrium that we want to assess. No myometrial cysts or islands have jumped out at me so far. Those are direct features. And as I really scan through and critically assess for subendometrial buds and lines, I usually will zoom up a little bit to do that. And so I'm just watching that contour around. And it's possible that right here, we're getting a very subtle change in the shape, in the line. If we were to draw a line across there, we're getting a bit of an interruption. This is very subtle. One of the things that I think we're going to be seeing a lot more in the coming years is how do we stage adenomyosis? If we have this teeny tiny little bud there, and that's the only thing we're seeing, does that count as adenomyosis? And what are we comparing the ultrasound against? If this patient ultimately undergoes a hysterectomy and the pathologist is cutting up the uterus and analyzing the histological characteristics, this is so small. What if they miss that? Is the ultrasound right? Is the pathology specimen going to reveal it? So unclear, but I think overall, this is not really going to be the contributor to the patient's problems overall, as that really is the only thing that I'm seeing there. For anybody watching, if there's ever anything that you see that I don't see, make a comment below and help me find things that I haven't seen, because I always want to learn as well. Pretty obvious, haven't seen any fibroids as we're scanning through. We're looking for hypoechoic spherical structures, so no fibroids. Moving on. Okay, some measurements. We don't need to belabor this too much, but it's a pretty normal sized uterus for somebody who is parous, somebody who has had pregnancies and deliveries. 3 deliveries, remember, so 140 mil uterus, pretty okay. And we got an attempt here at a 3D render, which I would say is an overall pretty good attempt. One thing that our sonographer could have done on this bottom right is to turn this 90 degrees to the right. We're still working on some of the settings on our machines to output a beautiful render right away without any manipulation. And there could have been a little bit more rotation in this B plane here to help highlight this cornua here on the right side. But otherwise, from a congenital anomaly standpoint, it's pretty good. From a junctional zone standpoint, we're seeing some there, some there. Not that I was particularly worried about that based on the cine loop. And I would say what we're not seeing here, if I were to really zoom this up, I would say we're not seeing any real evidence of a polyp. I could try and play around with that a little bit. Maybe, just maybe, if I convince myself a little bit brighter area here, but I don't think I would have really noticed that had I not already seen suggestion of a polyp on the 2D cine loop. Reset that. Okay, moving on. So my sonographer is spending a little more time with cine loops. I think now they've done their measurements, they've done their routine things. They're going to go deeper and try to find the pathology. Maybe they already knew that it was there, maybe not. Maybe now it's when they're really seeing it. So I'm not getting anything new on the cine loop, I don't think. Just going to pause it and scan through it. What I already think we knew about was this area right here, which I still know about. Not a whole lot else for me to see here. Aha, so yes, they have they've measured this structure here. This definitely I see as the area in a sagittal view. Interestingly, on this transverse view, what we're measuring looks more in the posterior aspect than in the anterior aspect. So not as convinced that this is actually what we're supposed to measure. Let's see, if we pause this transverse view, you have to remember when we're reporting, we're just seeing tidbits of what was captured by the sonographer in real time. So they really are the person who should be the main person to detect pathology. So I'm thinking more right here is where that polyp is. I think it's anterior because we know it's distorting, displacing that line posteriorly. So I think that's the area of focus. Though for what it's worth, what I'm also seeing here is a little bit lower. We're seeing a bit of maybe an anterior displacement. So could there also be something here which looks like that area that might have been measured? We come back to this cine loop. Let's see, can we see another polyp maybe? They often happen together. So we have this area here, which is displacing this midline linear echo posteriorly. And then just maybe inferior to that posteriorly, just here, maybe we have an anterior displacement of this endometrium as well. So could this be another polyp right here? Not as clearly depicted with respect to the edges, but I am seeing a shift in that endometrium. Is that because there's a posterior polyp, or is that just because that anterior polyp has shifted that endometrium posteriorly, and then where it normalizes, we're seeing the return of where the midline linear echo should be? A bit unclear to me. I am a huge believer in sonohystrography as a diagnostic test, but also potentially as a mapping tool, whereby you can really further clarify, is there one polyp? Are there two polyps, potentially more? Could there be other occult intracavitary pathology here? Sometimes. Let's see what else we got. Okay, so in this, coming back to this one here, our sonographer has turned on our color Doppler, and I'm not really getting a whole lot in the sense of blood flow to this. Maybe we're getting a bit of a suggestion of a feeding vessel just there. Hopefully we've turned that color Doppler on again. Okay, so here my sonographer is very technically skilled in performing what we're calling a endometrium or polyp sliding sign, where we're applying pressure to the uterus, and by extension, that pressure is applied to the content within the cavity to try and reveal sliding between the structures in the cavity. We're definitely seeing a difference in the movement of the structures posteriorly and anteriorly, but in transverse, I'm not seeing quite a lot of sliding per se. Okay, and here we have a transverse view with the color on. You know, it's pretty diffusely vascular, so nothing here is really focal. What I might try and tell you, let's see if I can figure this out, is where the patient is in the cycle. So last period was essentially 13 days ago. So this patient is probably about mid-cycle, though not always true if the cycles are a little bit longer. So anyway, the endometrium is definitely a bit on the thicker side, which I don't actually think we measured. Did we measure that? No, I think we might have forgotten about that, but let's just get a measurement here. So it's about 12.5 millimeters, a little bit on the thicker side. So at that point, we start to get secretory changes maybe that are going to lead to a bit more vascular flow within the endometrium. Polyps are definitely better assessed when the endometrium is thin, right after a period. Okay, so here we go again. Here's that technique where we can apply pressure and see if we can achieve sliding between structures. And so very subtle. I'm gonna zoom this up here. And then I'm gonna push play again. Will it play if I zoom it up? Not quite. Maybe if I do this. So what we're seeing, it'll be a bit back and forth here. But we're seeing in this region here, oh no, did it stay? In any case, what we're seeing here is definitely some sliding from the posterior to the anterior. And so that might indicate here that we do indeed have a little polyp in this region. And just, oh my gosh, let me get rid of that. Just at the end of this clip, I think it's at the end. right around here. If people watch this, I'm wondering if we're seeing a little bit of a sliding here between the potential posterior polyp and the junctional zone. Watch this spot right here. Maybe. Very subtle, very subtle. This one I'm definitely convinced about. That anterior one, that one to me is already pretty convincing. You can see it squishes there in this clip. You can see it slides a little bit towards the fundus. So that one is definitely a little bit more convincing. Okay, moving on to the ovaries. All right, we have a cine loop of the right adnexa. We're going to scan through this. We have a dominant follicle there. Makes sense. This patient is around mid-cycle. And as I scan through, I'm seeing a pretty normal follicle pattern, pretty normal size ovary. Based on the presence of the dominant follicle, this volume makes sense. It's 11.9 milliliters. And that dominant follicle there is even maybe a little bit collapsed. Does it have a peripheral ring of vascularity? I knew that was the next picture coming because that's the sequence of events in my brain. Nah, a little bit. So has it just ovulated? Quite possibly. A little bit hard to tell. Day 13 is maybe a little bit early. Day 14 is more typical, but if this patient has slightly shorter cycles, that might make sense. Okay, my sonographer, a little bit out of order here, but probably realized, ooh, I didn't get the endometrial measurement. We got around the same number. But this picture also really shows that nice demarcation there between the anterior and posterior endometrium where that polyp is. Coming back to the ovaries, left side. Okay, so this sweep on the left side is curious to me. Definitely subjectively a lot of follicles present. A lot of follicles present. Let's just take a slower version through that. Okay, so that one there, curious about measuring it. So it's about 9. 9s are cutoff for when we can include the polyp in account for the assessment of polycystic ovarian morphology. That one wouldn't count. So I'm getting about 2 that probably don't count here, but a lot that do. Let's have a look. So the volume of this ovary is also over 10 milliliters. It's also 11, but there's no dominant follicle here. There's no cyst here, and there's no corpus luteum here. So already this volume has a feature of polycystic ovarian morphology, which is a volume over 10 milliliters. And then let's have a look. So clearly my sonographer is doing another cine loop through this because they are also counting. They are also counting because they have the subjective sense. I am really on my sonographers to count. I think we are potentially underreporting polycystic ovarian morphology. And I think it has a lot of importance to a patient's overall well-being. So really key to report it. Let's count for the sake of it. So 1, 2, 3, 4, 5, 6, 7, 8. We're not counting that one. 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. So I'm getting 23. I don't know what all of you got at home. Maybe you counted along with me. I'm getting 23. So I would certainly consider this to be a polycystic ovarian morphology. Now, that doesn't mean this patient has polycystic ovarian syndrome. It just means that they have an ovary with a polycystic ovarian morphology. They also require several other criteria to meet the ultimate diagnosis of polycystic ovarian syndrome, PCOS or PCOS, as it's called in some other places, including potentially cycles that come far apart, including biochemical or phenotypical signs of hyperandrogenism, typically hirsutism and or acne. My sonographer, I think, has probably gone back to the right ovary for the purpose of the cine loop because they're thinking, did I miss PCOM in the right ovary? And I don't think so. We could count as well, but I actually don't think this ovary would meet criteria at this point in time. So let's do it. I think this one probably wouldn't count here. This one is going to be over 9. So we got 1, 2, 3, 4, 5, 6, not counting that one, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. I get 16 on this side, so I don't think this one meets the criteria. Coming back to the uterus, a little bit disjointed, but that's okay. The point is make sure that you have collected all the images that you need. And so on this side, my sonographer has more, I'd say, clearly shown that this anterior polyp has a feeding vessel. But notice this area posteriorly does not. So maybe there is no polyp there. And I think just for the sake of it, one last cine loop through the uterus. This is the last cine loop here. So for me, I'm going to report this as quite confidently identified singular polyp in the anterior endometrium, about mid-cavity. It's not a particularly big polyp overall. I'm not going to report second polyp because I don't really have much diagnostic confidence in that today. I don't think that there really are any other abnormalities within the uterus. In the right ovary, there's evidence of a dominant follicle / very potentially fresh ovulation. And on the left side, there's a polycystic ovarian morphology. Interestingly, it's possible that the polycystic ovarian morphology could be yielding a slightly hyperestrogenic state, which would actually be a risk factor for an endometrial polyp. And so maybe something to think about. If we are seeing polycystic ovarian morphology, are there other things that could be contributed to by a hyperestrogenic state, like polyps, fibroids, endometriosis? Some of these pathologies, we don't fully understand why they arise in the first place. But this patient does have abnormal uterine bleeding, heavy menstrual bleeding, and the polyp can be a good cause for that. As such, this patient should be seen by a gynecologist, if not already, to have the polyp removed. In this case, because I have a lot of confidence about the presence of a polyp, and if there was a second polyp, would it change the plan for the patient very much? Probably not. So it might be a little bit of a surgical surprise if a gynecologist performed a hysteroscopy in order to identify a second polyp. Probably not super pleasant, but also not going to be such a game changer moment. They both can be dealt with at the same time. Would we recommend something like an IUD in this case? No, probably not. The IUD might achieve endometrial thinning, but the patient might have ongoing spotting because of the polyp. So I don't think an IUD would be a great option for this patient at this time. So I think that's all from my perspective for this case. I think it was a really good depiction of ultrasound for polyp. Sonography could be used. There's nothing wrong with suggesting it to get confirmation about a potential second polyp or other potential intracavitary pathology, but I don't think it's going to carry that much utility here, so I wouldn't recommend it. If you're unclear about the presence of a polyp, and sometimes you are, because they can be very hard to see, then I think it's a great idea to recommend it to use as a tool diagnostically, but pre-hysteroscopy. Hysteroscopy is a bit more involved, a bit more expensive, and so making sure that you're going to send people appropriately to hysteroscopy is key. That's all for now. See you next time on GRWM, Get Reporting with Me. I'm Dr. Matthew Leonardi.